All right, welcome everybody. Thanks for having me. And it's a pleasure to be here. I work with some people in the crowd here at the Ottawa Hospital regularly, so you guys should be somewhere else in someone else's room. You've learned enough, we've worked enough together. You're sick of hearing from me, hey Andy? Yeah, okay. Thanks again for having me. I hope this talk will be good. You know, one of the things is know your crowd. I do know what you guys do, but I don't know exactly. I haven't been to one of your conferences before, so I hope you'll find this okay. And if you have any questions, it's informal, so speak up. So, I guess first I just talk about what I do. I mostly do trauma, so about 80% of the time I'm taking care of people with broken legs and broken arms, which is common for orthopedic surgeons. Being a trauma guy in the trauma center, we take care of regular fractures, a lot of hip fractures, but we also do a lot of more complex fractures. So they're difficult sometimes, and that's just something to be aware of when you're working with people that do that. And sometimes we have difficult patients at times. I like to say to our residents that even though they're difficult, they still have mommies and daddies, so we have to be nice to them. It's very rewarding work. You know, taking care of a broken femur fracture, you get that kind of direct visualization, immediate fixation, immediate improvement for the patient that some fields of medicine don't have. So certainly it's one of the reasons I think some of us go into it. It's very rewarding work. So this here is a patient of mine. I just thought I'd show you because the interesting thing about this case, you can press play there, is that this patient injured himself while called kneeboarding. So this is at spring. This is outside. This is near Kingston. You can see the water's breaking up. There's ice. There's water. And he's decided to kneeboard behind a snowmobile from the ice into the open water. Now, one thing we don't realize when someone comes in, this guy just had a femur fracture, but watch what he does here. So I think the thing you'll see here in slow motion as it comes around is that he just had a femur fracture. That's it. So he turned away at the right time. He protected himself. But what's interesting as you watch this in slow motion is how fast these guys, when you have a 25-year-old that has a broken femur, they are moving. It's hard to break your femur. So that's just an example, and a lot of your bones. So you can see here, watch the side view. I mean, he's barely touching the water there. He is just skimming the water when he hits that post. So he came with a femur fracture, and we took care of him. So the goals of the talk for today, I guess I was going to cover was from a surgeon's perspective, from my perspective, or our perspective of a surgeon. You know, I thought I'd cover a couple things: fluoro in the operating room, X-rays in a trauma patient. What do we look for? Pretty simple, a good X-ray. And what are we looking for when we look at X-rays? I had wrist and ankle, but as I went through the talk, it was getting a little long, so I'm just going to cover wrist as an example of some of the things we look at an X-ray may be of interest to you. So first thing I guess I'd say is when we're working in the operating room, and I work with some of the people here, it is a team approach. I do consider, you know, I guess myself performing the surgery as the leader of the team, but certainly it's still a team approach. And, you know, at the end of the day, the goal is to take good care of our patient, perform a good operation for the patient, and also try and do it efficiently, try and get it done so that we can, you know, the patient doesn't spend a whole bunch of time in the OR. And so that involves myself, our resident, the nurses, and the rad tech. Well, we do have to talk about surgeons a little bit. So qualities of a surgeon. I mean, one of the things we know, how people think is that, you know, we're well organized, practical, hardworking, intelligent, accomplished. These are some things that I won't say for myself, but some things have been attributed to a surgeon in the OR. But then the next one is cantankerous, dominant, hostile, a poor communicator, maybe a bit of a bully. So that's been kind of something that's dogged surgeons in particular. And there's a lot of literature on that. And so it's a little bit embarrassing, I guess, in this day and age. But I think things have improved a lot. I think times have changed. So I'm going to give you guys a test here. I'm going to say, are these things a surgeon said? Okay, so here, I'm going to give you this here. So my IQ is one of the highest, and you all know it. Please don't feel stupid or insecure. It's not your fault. You guys picture a surgeon saying that? Okay, here's the next one. What separates the winners from the losers is how a person reacts to each new twist of fate. You guys still think a surgeon said that? Okay, you guys can start. Anybody know who said these things? Anyone? How about this one here? My fingers are long and beautiful, and it has been well documented as various other parts of my body. Okay, I'm going to help you out here. This will be even better. I've said if Ivanka were my daughter, perhaps I'd be dating her. Did a surgeon say this? You guys know? These 4 quotes? Okay, all right. So I hope the new surgeon is not in the same class as this guy here. I hope we've moved on a little bit. But the bottom line is there is literature out there on patient safety, and this is a paper actually, Being a Jerk in the Operating Room, and I think it's important, and the reason I bring this to you, if you're new or experienced or a leader, is that there still is a working environment you have, and there's people factors. 70% of errors we feel are related to communication, and if a surgeon or anybody is intimidating, then people aren't willing to speak up. The team isn't willing to speak up, so they'll be scared to address a certain concern. So we want to make sure we kind of get away from that kind of attitude. So don't be scared to communicate with your surgeon, nurse, anesthetist. If you see something, I know you're just doing the x-rays, but if you see something going on in the OR, speak up. If you see something that can improve the operation, you can speak up. We're all here to take care of the patient. But I would say that you still have to remember the surgeons are leaders. Some operations are stressful, and we are human. So when we're in the middle of an operation that's a bit stressful, you got to make sure you approach it in a certain way, I guess, that makes it a good working environment yourself. So just because we oppose an idea doesn't make us disruptive. It just means we're trying to think of the best way as well. So again, we're all here to take care of the patient. So effective teams practice excellent communication. Bad environments, hostile culture prevents team members from voicing their concerns. And so the operating room does not function as a democracy, but at the same time, we have to make sure we can all communicate together. So that's the surgeon part of it. And we're trying to teach our surgeons. I would say the new surgeon, or I think that we've learned to be improved. But again, we're still stressed at times during the surgery, and so that comes across sometimes. Well, what about you? What about the perfect tech? That's what we're going to get to here. Well, here's some of the things that we would maybe hope that we can get out of you. Ensure radiation safety, minimize radiation, give us great pictures, great images, communicate with us. And also, the one big thing I want to talk about, and this is a pet peeve of mine, is avoid contamination in the operating room, which you can help with. So, first is obviously radiation safety, and I've seen your program, and there's a lot of talks on this, and I'm not the expert. I mean, I know some of the basics for sure on radiation safety, but you guys are the experts in this, so I'm not going to spend too much time in this. But certainly wearing your lead is important. I saw the last talk on, by the way, I want one of those live dosimeters. That looks cool. Can I have one of those? Why did the vascular guys only get that? That doesn't seem fair. Okay, so we want to minimize radiation. So we know all the appropriate things. Use appropriate dose of radiation, the direction of the drum. These are all things you guys are experts in. Minimizing the field. Ensuring maximized distance every time you take a picture. So I think you got to make sure your patient, now again, you got to work with a surgeon on this because sometimes we're holding a fracture. But if not, have them, remind them that they can stand back a little bit, and in particular try and minimize your hand exposure. And I got to say I'm guilty sometimes when I'm in a case that's not going well, I want to get it lined up. So I'll do a couple pictures with my hands near the field. But I do try and minimize that. One thing I'd say about minimizing the field is this. One of the things that frustrates me a little bit when I have some of the techs in that maybe aren't as experienced is you can minimize it, but you can't. If you minimize it too much, then you end up taking 40 x-rays. So you have to make it a field that they can see appropriate, but obviously you don't want to make it a field where you're seeing stuff you don't need to see. So there's kind of a balancing act there. And of course, the direction of the drum, the distance you stand away from the beam, obviously the square of the distance. So even if you stand 3 feet versus 2 feet, it's a huge impact on your radiation safety. So certainly you can help teach the surgeons and residents this. Another really important factor, survey of terminology used in the intraoperative direction of the C-arm fluoroscopy. So I think we're pretty good at this in operating room, but we're not perfect. But this is actually a paper written and published in Canadian Journal of Surgery by a guy at Sunnybrook. I don't know if anybody here's from Sunnybrook. Looking at language used when we're talking about X-ray, because the more consistent you are with the language, the more unnecessary X-rays you'll take, and the more X-rays of body parts that don't need to be X-rayed you'll take. The less. So there has been inconsistency among surgeons and techs, and this leads to unnecessary X-rays or poor quality images. So in this study, they came up with some terminology, and I would say that I use this terminology pretty routinely, but I also use body language. So I use both. I use communication. So I just tell them, okay, go this way. But if you work with a surgeon who's having problems with this kind of thing, I think between cases, talk about it. How can we communicate better so we can minimize X-rays? And they came up with this terminology, which was raise and lower, fairly straightforward. Come in with the X-ray or come out with the X-ray. That seems fairly forward. They said come distal on the body or proximal. And if you want to use north and south, that's fine. That can be a little confusing. But as long as all your people use the same terminology, it's okay. I think probably proximal and distal is better. Rotate over or rotate under is another term. Or rotate over and rotate back. And then tilt distal or tilt proximal. This would be kind of like an inlet X-ray. Swing proximal or swing distal. So these are terms that were published in the Canadian Journal of Surgery about 3 years ago. I'm not going to say that every center uses these exact terms, but I think it's a good idea if there's a problem that you see going on in your OR all the time, to talk about this. Bring this paper up or bring these pictures up. We can get them to you. But some terminology that's consistent amongst all the techs and the surgeons. So common language increases efficiency in the OR, decreases radiation use in the OR. And here's another paper that was published where they did use a standard communication between the surgeon and the rad tech. And they looked at the time to the perfect circle when performing an IM nail. And when you use good communication, they decrease the time to do it, and they decrease the radiation exposure to do it. So this can have a huge impact, little things like that. Next one I want to talk about is just contamination. And this one I think is one that any of the new techs and even the experienced techs don't pay attention to quite enough. And you don't see it, but I can tell you when a patient comes back with an infection into my clinic, I see it. So we want to avoid contamination when we're working. So there's the sterile field, there's the X-ray machine which has a sterile drape on it, but we want to make sure we don't contaminate the field we come into. So we use a sterile covering, but that sterile covering does not guarantee that you don't contaminate. So here's an example of one. There's not much literature on it, by the way, but I'm going to show you a couple pictures from our OR. This is a paper that was published comparing 3 C-arm draping maneuvers. And this is something not available in a lot of hospitals, but I can tell you the Ottawa Hospital actually opened up to this, so we use this C-armor drape now. I think several centers using it, but not all. So the techniques they looked at were just a standard drape that you'd hang down low to the level of the floor. And when you can see the image on the left was when there's an AP being performed, and on the right it's when they come up to a lateral. So the drapes just come up with them. And the next picture, you'll see a lot of surgeons use an accordion type thing. So the reason that is because you don't want the middle portion of the sheet to drop too low. So you accordion it and clip it during the AP. And then as the C-arm swung up to a lateral, you let go of the accordion, and then it keeps the drape a little bit higher. And then this is something called a C-arm, which is something we have to purchase, which sticks to the drapes, and then you can see the pocket that is formed that protects the C-armor. So in this technique, technique 3, the one with the C-armor, had the lowest technique. And again, I think you can use this and apply this. You don't have to have the C-armor, but certainly the C-armor in this study had the lowest contamination factor. And again, forget the cost. Like you could work in you could say how many patients get an infection out of this, because that's going to cost the hospital a lot of money. But even the cost of the drapes. So when you buy these C-armors, they cost what, $40 or something like that. I'm not sure how much they cost. I think it's something like that. But the amount of drapes you go through is probably not that far off the $40. So it'd be a cost. It'd be kind of a cost thing you'd have to look at. Here's some pictures from an OR I just did recently where we were using the C-armor. And this is something else. The C-armor is good on the one side of the patient, but on the drum side of the patient is where my biggest concern is. So you can see here we're on a lateral picture. When we come back to an AP, now I've exaggerated this, but we could be X-raying the other leg. So let's just say we were operating on the left leg in this case. See what happens here is the drape. You see the drape, and that drape's not bad, but that drape is almost touching my patient, and that drape was under the patient. So if you're trying to perform sterile technique, it's hard to do when the drape was under the bed, and now it's come back up and it's touching the patient's leg you're operating on. And I can tell you this is the number one, I think. I haven't done a study. I want to do a little medical student resident project where I sneak them into the OR and observe this, because I think the chances this happens in my colleagues' ORs is high, because we all don't pay attention to them. So you can see one of the things we do have is this, different, you may have different draping techniques that cover the whole C-arm. Here you can see this blue drape that holds back some of the plastic to prevent us from contaminating the patient. So these are really important considerations for you as you're working in the OR. The infection rate is fairly low in orthopedic procedures. It depends which one we're talking about, but let's say an IM nail of a tibia or femur. But some estimate that 20% of infections are due to intraoperative contamination. And I can tell you in nailing procedures, I think the chances that is due to myself and the tech is probably pretty high compared to the nurse grabbing something. So I think that's a common source of contamination. So try and minimize this. And I mean, the other comment I just make before I move on to the next topic is to say that we're working with you also kind of about ergonomics. So where do we place the fluoro? Where do we place the TV? That's going to be a surgeon preference thing. And I'm not going to go through every type of fracture and where I'd position it. But I think when you see a surgeon struggling to look around the C-arm, just work with him or her on getting a better position for the C-arm. And some of our new machines have the TV so you can see, which certainly I think is helpful instead of you having to stand on your tiptoes and look for where the best X-ray is taken. So that was fluoro in the OR. I was just going to talk a little bit next about X-rays in the trauma patient. And there's not as much to cover, but just a few points I wanted to make to you if you're working in eMERGE and taking X-rays. I would just say we meet every Monday morning and we go over the weekend's cases or what's scheduled for that week. So it's called our trauma rounds, and the surgeon that was on call on the weekends is there. The surgeons that are going to be in the trauma room that week are there, and we review cases that have been done or that are pending. A lot of times the patient comes in and they might be too sick for an operation, so he gets temporized either with traction or an external fixator, and then we say, okay, well, he or she's going to be ready for Tuesday. So we kind of plan our week, and it is also a chance where we get to pick on our residents and ask them lots of questions and say, what do you think? So one of the big things is once you go through the history and physical, the next thing is, okay, what do you see on the x-ray? And once you see what do you see on the x-ray, what do you want to do? And the first thing I always pick on them is I usually say, what do you see on the x-ray? I see a broken fibula. Well, hold on a second. What images are they? So it's an AP and a lateral, the distal tibia. And on this x-ray, I see this. So I want them to know what x-ray they're looking at. Because when I do that to them, a lot of times they say, well, it's an attempted AP, but not a very good one. And then I usually, at that point, turn to the resident that was on call on the weekend, and I say, how come you're not bringing us good x-rays to rounds? So the only way to plan a proper surgery is to have a good x-ray. So I grill that into our residents and make sure we have appropriate x-rays. So here, an example, 50-year-old motorcycle accident. She comes to the emergency department, she goes through the trauma protocol, and actually, in the end, she has an isolated injury. She has a femur fracture. Well, not isolated. She has a femur fracture and a tibia fracture. And the Gastillo 3B means it's an open fracture, so the bone's sticking out of the skin. So it's an open tibia and a distal femur. And this is done in one of our community hospitals a couple hours outside Ottawa. And there's orthopedics there. And these are the x-rays that are done. So this is a very typical x-ray we see at our hospital sometimes. Sorry, guys, on occasion. Most of the time in our place is better, but this is an x-ray that's done. So there was a lateral which was worse, but you can see there's an AP of the femur and AP of the tibia. So there was no other x-rays. I checked with the hospital, no other x-rays done, and the surgeon went and operated on this with these x-rays. So from my standpoint, I don't think you're going to be ready to perform a good surgery with that x-ray. So here's what the surgeon did. Fix the tibia. Now again, this is pre-op planning. I think the reason there's 3 plates on the leg is because the surgeon didn't realize he didn't have long enough plates to start the case with, and then in the middle of the case just started using a couple of plates. So anyway, that's maybe beyond what you're interested in, but you can see that he didn't pre-op plan before, so then intra-op, he's just kind of going to the OR and doing stuff. And then same with the femur. So the femur, and again, we have some great surgeons in the province. I mean, great care, and I do make some mistakes where I fix something I could have done a little bit better. It's a very stressful environment, but for the most part, I think we're quite good at what we do. In this case, the plate's put on the femur, and the femur is not perfectly reduced, not perfectly straight, not too bad, but I would tell you this, it's most likely based on the, do I have a pointer here? I don't know if I have a pointer. Oh. Like in here with that here, it's probably rotated, so it's rotated off. But then what you can see is the surgeon didn't fill the top screws. So why didn't the surgeon fill the top screws? Well, maybe the surgeon felt there was enough fixation, but I would tell you that most surgeons would say that when the fracture ends here and the last screw is here, probably not quite enough for stability. But when you go to a lateral x-ray, you can see the reason he didn't fill the screws was because he had laid the plate down, started filling the screws, and then the top 4 screws weren't on bone, so he just said, okay, well, I'm not gonna fill those ones. So he didn't do what I'd say is a technically great job in this case. And even when you don't do a great job, the patient may heal the fracture. In this case, she got transported back to Ottawa, went on, didn't heal her fracture. She actually got taken care of locally, again, not at our hospital, and had a change to a rod, which is not bad, actually. Alignment looks pretty good now. The femur looks pretty straight. Surgeon felt that it wasn't healing, so did something called dynamizing the rod, where they take the screws out and allow the fracture to start compressing. So you can see where the screws have been taken out. And it's not a bad idea, but what happened to this patient was they dynamized quite a bit, so you can see that the rod is starting to stick into the knee joint. So then the surgeon decided just to take out the rod and hope that it had healed enough. And that's, again, I would say not terrible, but so anyway, in the end, the patient wasn't healed enough. So after 2 operations, got referred to us. So you can see, just to show you like a case that can, and again, it can go bad if it's not planned properly. And part of the planning is really, truly how good the x-rays are. So in this case, we ended up, and this is us planning. We're determining how much leg length discrepancy there is now that the patient's had 2 surgeries. So she only had 2 centimeters leg length discrepancy, so it wasn't enough to have to worry about the leg lengths. And we have proper x-rays, and then we take her to we rule out infection, plan the revision surgery, what options there are. We put a plate and screws on, compress it, and then this is her at a year. So she could have it wasn't that hard of a fracture, could have been avoided. Just another example. This would be in our rounds. And this is a patient with an elbow fracture. And the x-rays are taken, and again, I know the situation because the patient's already been splinted. So when you go to the x-ray the patient, you actually can't do a fully extended film. So I know that you can't always do a perfect x-ray. All you can do is do your best. But in this case, it's hard for us to assess whether to do a surgery unless you have better x-rays. So one thing we may do it nowadays is get a CAT scan. That's one thing we could consider. But I really do like to get good x-rays. So a lot of times in the OR before I do the case or down in eMERGE, I'll try and do some traction x-rays. So these are x-rays you want. You want a good AP and a good lateral. So just a lesson on the worse the patient is injured, usually the worse the x-ray is. And that's because it's a difficult x-ray to take. It's kind of like performing surgery on a bad case. So I guess my point to you guys would be put the effort in, the more significant the injury. Try and get good x-rays for us as best you can. I say take pride in performing a good x-ray. Don't torture the patient. I mean, if they're broken and you can't move them a certain way, then you have to ask the doctor for some help. I'm not saying that you should do that, but discuss it with the surgeon and try and get it done because one x-ray and I'm done, I'm out of here is not kind of the attitude to have. We want to have a good x-ray. And the other thing is, a lot of times what happens too is the patient gets their x-ray and eMERGE, it's not great, they get shipped up to the ward. Well, at this point I'm like, oh, well, I can't bring them back down for an x-ray. So, get it done right when they show up. So that's my stand on my high horse lecture for getting good x-rays. Okay, next one is what are we looking for? Are we too long or we're good? 10 minutes. Okay. So I just thought I'd use x-ray wrist as an example. A lot of you that spend a lot of time know what we look for, but basically when we're doing an x-ray of a wrist, we often do an AP and a lateral, sometimes an oblique x-ray. And there's multiple other x-rays that we may ask for, but typically those are the first three. Just to show you what we look for in a lateral. A lateral x-ray is a straight lateral, but the best lateral is actually a 10-degree tilt. And that's what we do in the operating room. And I'll show you the reason is because you can see here that if you get an x-ray, you won't see the joint, but if you have an angle here, you'll see down the wrist joint a little bit better. So it allows better visualization of the articular cartilage of the distal radius. And whatever standard in your hospital is fine, but I would say in our plaster room, Andy, we're doing tilts usually all the time, or only if we ask for it? On recheck, we usually do, so we can see down the joint. So I'll show you a picture of that. So there's a normal lateral. It's fine, but then you can see that the 10-degree lateral really shows that radiocarpal joint quite well. So in our place, typically in our plaster room, we're doing an AP and a lateral. And the lateral, we actually do it a little bit of a tilt, so we can see down the angle. So this can be a useful view to allow better visualization of the articular cartilage. So how do you assess adequacy? First, I just say AP is some debate too, whether you do it in pronation or whether you do it in neutral. But typically, this is a pronated AP versus a supinated AP. You can see the difference at the bottom. One of the differences, there's several differences when you do an PA or an AP, and so we look for this. How did the X-ray get done? But one of the X-rays you can see in the bottom left is how the ulnar styloid is positioned. So in a pronated view, the ulnar styloid is straight lateral, and if it's a supinated position, it's not. You can actually feel that on yourself if you rotate. You put your finger on your styloid, piece of bone right here, and you rotate your wrist. You can feel your styloid when it's like this, it's out to the side. But when it's like this, it's on the back of your wrist. So that's just one pointer on the X-ray we'd look for, and we'd know that it's a pronated X-ray if the ulnar styloid is straight lateral like there. So on a true lateral X-ray, the pisiform bone should project directly over the distal pole of the scaphoid. And then another way is the third metacarpal should be lined up with the distal radius. So if I was to show you a picture, I'd say that you can see the pisiform and the scaphoid, the distal pole of the scaphoid, are collinear there. So the image on the right is a good lateral X-ray. Okay? So if the pisiform is dorsal to the distal pole of the scaphoid, so you have to think about that. If it's dorsal, okay, that means that you've got a lateral in a pronated position. And if it's volar, the pisiform is volar, then you have an oblique that's in a supinated position. So this is This is one of our residents giving a talk. If you really want to piss off the tech, some sources actually say a true lateral is like this. So it's the pisiform should divide the exact is the if you divide it into thirds, the volar surface of the pisiform should go right down the middle third of the distal pole of the scaphoid. So that's a true lateral. Basically overlapped, but the pisiform is maybe just a little bit, dorsal right there. So that's kind of the perfect. Okay, so there's a good true lateral right there on the right. Okay, so let's play a game. So I want to let you guys know that the Senators are still playing right now, and actually, they're playing right now. Anybody know the score? Anyways, the Leafs are not playing. Sorry about that. So we'll play a game. So is that a true lateral? So if I was to push the button, you can see the circle around the PC form, right? So the PC form there is fairly dorsal, so it's going to be a pronated view. What about this one here? So on that one there, closer. But if you look for the PC form, it's just a little bit volar. So if you're going to be picky, it would be a little bit less than that. But that's pretty good, pretty close. So there's a true lateral. You can see the PC form and the volar cortex. So that's some of the things we look for when we're looking for a true lateral. It's not perfect, but it's acceptable. So why is it important? Why is the true lateral important? One of the things about the lateral X-ray is when we're measuring something that we really look at when somebody's broken the wrist, which is dorsal tilt. When we measure the dorsal tilt, it changes depending on the rotation. So if you have a pronated or a straight lateral or a supinated view, the measurement of the dorsal tilt will be different. So the only way we want to accurately measure the dorsal tilt to decide if they need surgery or not is based on a good lateral X-ray. So what else do we look for? Just to mention some other things we might look for. You know, we look at the ulnar styloid. We look at the carpal facet horizon, which is basically the joint surface. And you can see here, right there, that's the carpal facet. That's the volar side, and then around the back is the dorsal side. And you have the styloid, and then, of course, all the carpal bones. There's lots more to talk about, but a couple things we look at: radial inclination. So radial inclination is this right here. You can see radial inclination. The radial inclination is the angle from the tip of the styloid to the ulnar side of the distal radius, and the normal is around 24 millimeters. Okay, so if you measure it. And again, if you have loss of your inclination when you break your wrist, I was going to put up all the parameters that happen when you break your wrist, but I don't think we have to go over that today. But so then the lateral view, what things we look for? Well, we look for the radiocarpal-articular cartilage. We talked about the joint surface. We look for the styloid. We look for something called the teardrop. And we measure the volar tilt we talked about. We measure the teardrop angle, and we measure the AP distance. So I think we have an X-ray here. So some of the things we might measure, I can't remember if I put it up here or not. Yeah. So if I was to go back, you can see the styloid right in here, right? And then this is the teardrop. And then we look for the volar surface. So we look at the styloid, we look at the teardrop, we look at the volar angulation. So there you pointed out in the white is the styloid. And here's why do we look at this? Because this plate here has been placed on the styloid. So when you go to lateral X-ray, you can see it's kind of down the middle on the styloid. And here we can measure our volar angulation. How good do we do the surgery to restoring the normal anatomy? So again, there's that volar tilt. So the volar tilt is measured this way. It's measured off the articular cartilage, the dorsal rim to the volar rim, and then coaxial with the length of the radius. And it's normally 11 degrees of volar angulation. So the only way to measure that is to have a good X-ray, a good lateral. What else do we look for? We would look for articular step-offs, meaning a step in the joint. We look for maybe a gap in the joint because we want a nice, smooth joint surface. The way I tell my patients is like driving down the road with a bump on the road. You want the road to be nice and smooth. We look for associated fractures of the carpal bones or the ulnar fractures. We assess the joints and we assess the carpal arches. So there's just an example of someone with an articular step-off that's large. So they have an interarticular fracture that's large. And anything more than 2 millimeters in articular step-off, we don't accept. So take-home messages, I guess, for that is just that we want to make sure we have 2 good X-rays, an AP and lateral, sometimes an oblique. We like the 10-degree lateral tilt. We want to make sure that you know what a true lateral is because that's important. And the PA film is either taken in pronation, typical pronation, or neutral. We would ask you to do it in supination. So take home from my perspective, again, take pride in your X-rays. The more severely injured the patient, the more severely injured the fracture is, sometimes the more difficult it is. So we understand that, but take some time to do in a good X-ray. Work with your surgeons in the OR to make a safe, efficient environment that is contamination-free. I hope you guys got that message. Pay attention to your draping and your sheets because they contaminate quite often. And there's many factors we look for, and I just used the wrist as an example about what we're looking for. So that's why we need these quality X-rays because we use them to make measurements to determine our treatment. So I would just say thank you, and once again, sorry, Andy, the Leafs aren't playing today, but go Sens, and that's it for me. Thank you.